Hi, Keegan here, talking more about AI in healthcare. So, something really neat happened recently. I did a poll on LinkedIn to see what types of things that I should talk about in healthcare, and healthcare AI and health-related social needs bubbled to the top. Something else happened where they met together in an exciting way, and I'll tell you why. So, first, going back to my first video talking about ways to think about AI in healthcare. And first is an important rubric is have a problem to solve. Try to solve it conventionally first, and there's a chance that you might need to add more human into that if you're relying on technology too much. So that was the gist of my first video on this topic. And then I discovered the blend of some interesting things. I'm going to share an article that I saw recently that talks about how to use large language models in risk prediction. This is a study, large language models for integrating social determinant of health data, a case study on heart failure, 30-day readmission prediction. This is super interesting because one of the typical problems with SDOH or social determinants of health data found in public data sets is a grain mismatch when you try to use it for clinical purposes. What I mean by that is that in the clinical world, in the EMR world, in the claims data world, we know a lot about a patient at a patient level. And then in the public data set, SDOH world that talks about economic dimensions, and they list through here different domains of SDOH data, social and community context, economic stability, education and access to quality, neighborhood and built environment, healthcare access and quality. These are all aggregated by the CDC, by AHR, by other kind of national and state and even regional government entities. And the issue is that this data is an aggregate. This is population level data, typically oriented around a zip code or a census tract. This is data sometimes collected during the census. And so there is incredible utility and application for being able to apply those population level predictions and tie them to a patient, but we don't have person level information or the version of those classified areas, like what is the average income for a particular geography, census tract, zip code that is at the population level, not at the person level. And so what this article does is it addresses head on, like back to my point about how to use AI to solve a problem. The problem here is linking those data sets on a person to the population level data. And I recall with one of my engineering teams saying, go do this, they looked at me sideways going, well, that's a lot of work. True. What you have to do is first classify these data sets into the different categories that I mentioned. But the other thing you have to do is find a way to link them and create a similar grain for each data set. And so what this article talks about is taking essentially that person level electronic health record or claims data and using a person's address to essentially geocode them to a census tract or a zip code that matches with those population data sets. And all of a sudden, between the classification and between that linking, you have valuable insight, SDOH insight on a person. And of course, it's protected information in the context of the study, but essentially this was focused on using a bunch of variables. It talks about how they first manually labeled 700 plus variables in SDOH datasets, and then used large language models or LLMs to do the labeling without detailed prompting. And we can go into more of that later, but this is a good example of having the problem of labeling and linking datasets and using AI and LLMs to do that more efficiently. I think beyond that, there's a lot of usefulness and utility for using public data sets to accomplish other public policy goals or payment goals, such as in New York State with the new health equity reform waiver and the investment in health-related social needs screening and the linking of people and payment of that linking of people to services, and then using that data in a more accurate way of risk adjusting payment for value-based care is a downstream application of this work. I also want to mention Mimi Labs and Yubin Park and what he's been doing with this in this initiative company, Mimi Labs, and public data sets that can in fact be used in some way for this purpose. And this is great. I love open source in healthcare. There's some AI features built in here, but a call to Yubin and Mimi Labs for cataloging the plethora of public data out there that you could use for any of these purposes. This is exciting to me because two of the things that I want to talk with the community about have come together. I'll be definitely digesting the article more, and maybe we'll do a separate video on that. More to come on Mimi Labs. Two, some very exciting initiatives that, from my perspective, if I had them 5 years ago or 7 years ago, would have made my technical journey in healthcare a lot easier. Thank you for listening. Keegan, out.